Welcome to the deep dive. Our mission today, it's pretty straightforward. We want to give you the ultimate shortcut to understanding the really complex web of influences on a child's health. We're pulling the core insights from Chapter 2 of Essentials of Pediatric Nursing.
And this is just so foundational for anyone working with kids. If you want to, move beyond just treating the symptoms, you have to see the child as part of a whole ecosystem.
Right.
Understanding all these factors, genetics, family, society. It's how you provide care that's actually sensitive, culturally aware, and crucially, how you connect families with the resources they might really need.
Okay, so let's break that down. We're mapping this ecosystem in like 4 main areas. First, the child's internal stuff.
Yeah.
Genetics and temperament.
Yep.
Second, their daily life, so health status and lifestyle.
Mm-hmm.
Third, the systems they deal with, access, family, culture.
Mm-hmm.
And finally, the big picture. Community and society, let's start right at the beginning. The internal coding. Heredity. It determines so much sex, race, even some behaviors, and definitely disease risk.
It's really interesting how these play out. Take sex, for example. We know certain conditions are more common in one sex than the other, like scoliosis in females or colorblindness, more often in males. Mm-hmm. And here's something maybe unexpected. Premature girls. They tend to have a better survival rate than premature boys.
Really?
Yeah. And then, of course, you layer gender on top of that, the social roles, cultural attitudes, totally separate from the biology, but just as influential.
And raise those biologically transmitted traits that's so important during assessment.
Yeah.
Right? Because you need that context.
Absolutely essential.
Yeah.
Because something like, say, epidenthal folds, perfectly normal in Asian children, might signal something like Down syndrome in children of other backgrounds.
Right.
Or think about sickle cell anemia. The risk is significantly higher for African Americans. You have to know the baseline to spot what's different.
Makes sense.
Now, moving beyond biology, let's talk temperament.
Right. Temperament. So this is the child's like inherent style, how they react to the world.
Exactly. It's their basic way of interacting. And it's a two-way street, The child's temperament really shapes how parents and others respond to them.
So understanding the types is key.
Oh, definitely. Knowing the 3 classic categories can be, honestly, one of the best tools for minimizing conflict. They're pretty distinct.
Okay, paint us a picture. What are they?
So first, you have your easy children. They're generally even-tempered. Their biological functions are pretty regular, predictable. They approach new things positively.
Okay, the easy ones.
Then, the difficult children. These kids are often intense, very active, maybe irregular in their sleeping or eating. They tend to withdraw from new situations initially and get frustrated more easily.
Right. That sounds challenging.
It can be.
Yeah.
And the third type is the slow-to-warm-up child. They might seem moody, they're less active physically, and they react to new things with a kind of mild passive resistance. They just need more time to adjust.
So recognizing these isn't just about labeling, is it? There's a deeper point.
Oh, absolutely. The real takeaway is this. When parents understand temperament, they stop seeing the child as intentionally bad or stubborn. They realize, okay, this intensity, this withdrawal, it's part of their innate style.
So it shifts the approach.
Exactly. If a parent can adjust their style, maybe offer structure instead of throwing a difficult child into total chaos, that inherent intensity can actually become a strength later on. Focus, persistence,
Yeah.
It reframes everything.
It's a huge shift in perspective.
Yeah.
Okay, so moving from the internal blueprint to what they encounter day to day, developmental level seems tightly linked to specific health risks.
It really is. You can almost see it as a progression of dangers based on what they're doing at that age. Infants, for instance, their immune systems are still maturing, so they're more susceptible to infections like roseola, which you often see between, say, 6 and 15 months.
Okay.
Then toddlers, they become mobile, they're exploring everything, putting things in their mouth, so the risk of accidental poisoning skyrockets.
Right, I can see that.
Preschool and school-age kids are active, running, climbing injuries, and accidents become more common. And then adolescents, they're figuring out who they are, testing boundaries, which unfortunately leads to injuries often linked to risk-taking behaviors.
And underpinning all this growth and activity is nutrition. It's essential, obviously, for brain development, physical growth.
Yeah, and in pediatrics, we often deal with both ends of the spectrum. You still see nutritional deficiencies like iron deficiency, anemia, but then there's the huge growing issue of excess childhood obesity. And that's really worrying because it brings forward the risk of things like type 2 diabetes and heart disease much, much earlier in life.
Wow. And then there are environmental exposures, even before birth, right, with teratogens.
Definitely. Things the mother might be exposed to, alcohol, certain drugs, even severe malnutrition can act as teratogens in utero. After birth, the threats shift to things like air pollution, safety hazards in the home or neighborhood.
And young kids are more vulnerable.
Much more so. Their bodies are smaller, their systems are developing so rapidly. Take lead exposure. It's sadly common, it's preventable, but it's incredibly dangerous for kids under 6 because it directly impacts their developing nervous systems.
Okay, you mentioned smoke exposure earlier,
Yeah.
but there was a specific type, third-hand smoke. Tell me about that.
Yes. This is critical. We all know about secondhand smoke, breathing it in. Third-hand smoke is the residue, the toxins and carcinogens that literally stick to surfaces, carpets, clothes, furniture, toys.
Mhm.
And because infants and toddlers are crawling, touching everything, putting things in their mouths, they get a much higher exposure to these lingering toxins. It's a hidden danger.
That's really concerning. So with all these risks, internal and external, what helps kids cope? You mentioned resilience.
Ah, yes, resilience. It's that amazing quality some individuals have that allows them to face significant stress, real adversity, and still manage to function well and achieve positive outcomes.
What builds that resilience? What are the protective factors?
We usually group them into internal and external factors. Internal ones are things within the child being proactive, feeling like they have some control, taking responsibility for their choices.
Yeah.
And the external factors are things like having strong, caring relationships, usually with a family member, but sometimes a teacher or mentor, a positive, safe school environment, and solid community support.
Okay, so we've looked at the child and their immediate environment,
Hmm.
but accessing care, the family structure itself, these systems are huge. Let's talk access. There's some good news here, right?
Yeah.
The rate of uninsured kids has dropped.
Yes, that's a significant positive trend. It's down to about 5%, which is an all-time low, largely thanks to expansions in Medicaid and the Children's Health Insurance Program, or CHIP.
But barriers still exist, big
Yeah.
ones.
Oh, absolutely. Despite the insurance gains, financial barriers are huge. Think about it. In 2014, 44% of children were living in low-income families. 44%. Then you have sociocultural and ethnic barriers. We see clear disparities in health outcomes, higher obesity rates, for example, in African American and Mexican American children compared to white children.
And the healthcare system itself can sometimes create barriers.
Yeah, paradoxically, things like managed care or payment systems based on diagnosis-related groups, DRGs, they're designed to control costs, often by pushing for quicker discharges from hospitals.
Okay.
Now, that might improve access to basic preventive care sometimes, but it can seriously limit access to necessary specialty care. Think long-term rehab, complex mental health services, developmental specialists. This is a massive problem for kids with chronic or complex health conditions.
And the family unit. It's
Yep.
the core place kids learn about health, isn't it? But that unit looks really different now than it used to.
Dramatically different. The idea of the traditional nuclear family, 2 parents, biological kids, it's just not the norm for a large portion of children anymore. The percentage of kids living with 2 parents dropped significantly between, say, 1960 and 2016.
So what do modern families look like?
Oh, all sorts of structures. You see binuclear families where parents have joint custody after divorce, commuter families where one parent lives elsewhere for work, lots of blended families with step-parents and step-siblings, and importantly, same-sex parent families.
And some families face unique vulnerabilities.
Definitely. We have to pay special attention to children in foster care. These kids often come with a history of trauma, instability, and significant unmet health needs: physical, developmental, emotional. They need a really high level of coordinated, sensitive care.
You mentioned divorce. Are there guidelines for parents to help minimize the negative impact on kids?
Yes, and they're based on reducing conflict and providing stability. Key things include: tell all the children together about the decision, make it crystal clear it's not their fault, try to maintain routines as much as possible, and this is crucial, never criticize or belittle the other parent in front of the kids. The focus has to stay on the child's well-being.
That makes sense. And what about adoption? You mentioned language being important.
Vitally important. As nurses, we absolutely must use positive adoption language. That means saying things like birth parent instead of natural parent or real parent, and framing the decision as the birth parents chose to make an adoption plan, not that they gave the child away or put them up for adoption. It respects everyone involved and supports the child's identity.
I need to circle back to something you said earlier. If nearly half of kids are in low-income families, and community support is listed as a key protective factor for resilience, How realistic is that?
Mhm.
Aren't resources often lacking in those very communities?
That is an incredibly important and sharp point. You're right, there's often an inverse relationship. The communities with the greatest need may have the fewest resources. Community support is a buffer, but its presence isn't guaranteed.
So what does that mean for nursing practice?
It means our role has to shift. We can't just hand someone a list of resources that might not exist or be accessible. We might need to actively investigate what is available. Maybe it's school program, a church outreach, a specific clinic, and sometimes we have to be that consistent, caring connection point ourselves when the broader community structures are weak. We have to help bridge that gap.
Okay, let's shift to parenting styles now, defined by that balance of support and control, right?
Exactly. We generally talk about four main styles. First is authoritarian. Think high control, but low warmth or support. Lots of rules, expects obedience without question. This style often correlates with kids having lower self-esteem, maybe less happiness.
Okay, high control, low support.
Then there's authoritative, sometimes called democratic. This is high control and high support. These parents have rules and expectations, but they're also warm. They listen to the child's opinion. They explain reasons. It's firm but fair. This style is consistently linked to the best outcomes. Kids tend to be more independent, self-confident, socially competent.
That sounds like the ideal then. What are the other two?
The third is permissive, or laissez-faire. This is low control, though support might be high or mixed. Rules are inconsistent, or maybe not really enforced. Kids from these homes might struggle with impulse control, maybe have trouble in school because they lack structure.
Okay, the low control.
And the last one is uninvolved or neglecting. This is low on both control and support. The parent seems indifferent, maybe overwhelmed, just disconnected. Sadly, this is often linked to poor outcomes for the child, like lack of emotional control, problems with attachment, anger.
Now, something that often gets mixed up, the difference between discipline and punishment. Can you clarify that?
Yes, this is vital. Discipline is really about teaching and guiding. It's an ongoing process aimed at increasing desirable behavior and self-control. Punishment, on the other hand, is a negative consequence delivered after an undesirable behavior has occurred, aimed at stopping it.
So discipline is proactive teaching, punishment is reactive consequence.
Precisely. And effective discipline strategies focus on things like positive reinforcement, catching the child being good and offering immediate specific praise or maybe a small reward. Another strategy is extinction, which means removing the reinforcement for an undesirable behavior. The classic example is timeout.
Timeout. Is there a rule for how long?
The general guideline is 1 minute per year of the child's age. But what's interesting, especially for nurses advising parents, is that by around age 3 or so, you can sometimes empower the child to decide when they feel ready to come out, which starts building self-management skills.
What about physical punishment, like spanking?
Well, it's common in some families, but major pediatric organizations like the American Academy of Pediatrics strongly advise against it. Research suggests its effectiveness decreases over time, it doesn't teach alternative behaviors, and it can actually increase aggression in children. So the recommendation is to use alternative discipline strategies.
Got it. Okay, shifting gears again, culture. Hugely important in pediatric care. We need cultural competence.
Absolutely. Cultural competence means having the knowledge and skills to adapt our care so it respects and fits within the child's cultural context. And a key part of that is fighting against ethnocentrism. That's the belief that your own culture's way is the best or only right way. We have to avoid that.
Can you give some examples where cultural understanding is critical, practices that might be misunderstood?
Sure. One example is coining, a practice sometimes seen in Vietnamese culture. It involves rubbing an oiled coin on the skin, which leaves bruise-like marks. Someone unfamiliar might mistakenly think it's child abuse.
Wow, okay. Need to know that.
Another involves certain folk remedies. For example, in some Mexican communities, powders called azarcan or greta might be used for digestive issues. The problem is these powders often contain very high levels of lead, which is extremely toxic, especially to children.
So awareness is key to safety there.
Right.
What about spirituality and religion?
Also very important. Spirituality is more about an individual's personal beliefs and sense of connection, whereas religion usually involves organized practices and community worship. Understanding a family's religious beliefs is crucial because it can shape how they interpret illness. Is it seen as a punishment, a test of faith, a natural event?
Right.
And families really appreciate it when healthcare providers acknowledge and respect their practices, whether it's dietary rules, prayer times, or specific rituals around health and illness. It builds trust.
Okay, let's zoom out beyond the family. to the community school, the neighborhood, friends, these all have a big impact too, right? Like school success being linked to health.
Definitely. Things like academic achievement often go hand in hand with healthier behaviors. A positive school environment is a huge protective factor.
But communities can also have negative influences,
Mhm.
particularly violence. The statistics you mentioned earlier are quite stark.
They are deeply concerning. Suicide is the third leading cause of death for young people aged 10 to 17. Think about that. Third leading cause.
That's chilling.
School violence is also widespread bullying affects about 1 in 5 high school students. And when we look at child maltreatment within the home, the most common form, by far, almost 75%, is actually neglect, failure to provide for basic needs.
It's sobering to think that for so many kids, the biggest threat isn't a disease, but their environment. What does exposure to violence do to a child?
The consequences are significant and can be long-lasting. Short term, you might see things like sleep problems, nightmares, increased aggression, headaches, stomach aches.
And long term.
Long-term impacts can include poor school performance, truancy, difficulty forming healthy relationships, and sadly, an earlier start to risky behaviors like substance use.
But even in the face of violence, you mentioned resilience can still make a difference.
Yes, thankfully. Even in really difficult environments, certain factors can buffer kids. Key ones include feeling securely attached to at least one caring, nonviolent adult, could be a parent, grandparent, teacher,
Mm.
also feeling committed to school, having goals for the future, and sometimes having a strong sense of cultural or spiritual identity can provide an anchor.
Okay, let's wrap up with the broadest influences. Societal factors, namely poverty and media. Poverty rates are still high.
Distressingly high. About 17.5% of children under 18 live in poverty in the U.S., and poverty is strongly linked to poorer health outcomes, lower educational achievement, and higher exposure to violence. It's a systemic issue with profound health implications.
And there's media everywhere now, TV, social media, games.
Absolutely pervasive,
Yeah.
and its influence is huge. The American Academy of Pediatrics, the AAP, has specific guidelines on screen time that nurses often need to discuss with parents.
What are the highlights?
Okay, so for kids under 18 months, they recommend basically no screen time except for video chatting with family. From 18 to 24 months, if parents introduce digital media, it should be high-quality educational programming. And this is key. The parent should watch with the child to help them understand what they're seeing.
Okay, co-viewing. And older kids.
For ages 2 to 5, the limit is ideally 1 hour per day of high-quality programming. For kids 6 and older, it's about consistency and setting limits on total screen time, especially sedentary screen time, maybe aiming for under 2 hours daily and making sure it doesn't replace sleep, physical activity, or other essential behaviors.
So the advice isn't just less screen time.
No, it's more nuanced. The AAP emphasizes creating a family media plan that works for that specific family's values and needs. And a practical tip is keeping media devices out of bedrooms and in common areas of the house, which allows for better monitoring and encourages shared experiences rather than isolated use.
Yeah.
Hashtag Hag Outro.
Well, we have covered a lot of ground. From the genes a child inherits to the neighborhood they live in. It really reinforces that a child's health is this incredibly complex mix of internal factors, family dynamics, cultural context, and socioeconomic realities.
That's exactly it. And for nurses, the goal isn't just to treat the ear infection or manage the asthma. It's really about seeing the whole child in their unique situation. What's their temperament like? What's their family structure? Binuclear, adopted, foster? What cultural beliefs influence their health practices? What are the daily stresses they face?
Right.
Understanding that whole picture, doing that comprehensive assessment, that's how pediatric nurses move beyond just technical skill to truly make a profound difference in the lives of children and families.
So as you take all this information from our deep dive into your practice or your studies, here's something to really think about. We know child poverty and neglect are strongly linked to poor health outcomes. So what specific, concrete, local community resources could you prioritize identifying or assessing during your next clinical experience to try and intervene effectively where that structural need is clearly greatest?